Thank you, Mrs. Chairman. Dear colleagues, dear ladies and gentlemen, I would like to talk about care approaches in Eastern European countries, and I would like firstly to say that I am pleased and honored to be invited here. And I thought that it might be pretty easy to try to talk about care approaches in Eastern Europe, as I am from Central European country, from the former Eastern European bloc. But subsequently, I was finding that it is not as easy, and there are much data that do not bring much knowledge and information. So I just rewrote my presentation, and I will just try to give you an insight into this problem. Firstly, I would like to start with this philosophical question: what is Eastern Europe? We use, especially here in Western Europe, to talk about Eastern Europe. But what is it? We have a geographical definition defining Europe as going from Portugal to Ural in the Russia and Caucasus. We have the political definition of former Central and Eastern European countries that were members of former political bloc under very strong influence of the Soviet Union. And now we define these countries also as newcomers to the European Union, but it is not also precise because there are many more or some more newcomers, including Malta and Cyprus in the same time. So I selected, because otherwise it would not be possible to bring a presentation within these 15 minutes or so, to talk about EU newcomers from the group of Central and Eastern European countries. I did not include Baltic countries because they have a bit specific problems because they were part of the former Soviet Union, and I also did not include Balkan and Turkey, as they are considered to be part of the southern and eastern space of Europe. When we look at the border, at the European border, so just this slide is to show that there is one very eastern border at Ural, then the border of Poland, Slovakia, etc., with Ukraine and more Eastern European countries. And this most to the left is shown that the eastern border of European Union was inside Germany. Because DDR, former German Democratic Republic, was also a part of Eastern European bloc under the Soviet influence. And I think that despite it is now part of Germany, that there are many very common problems that I will be speaking about. So I was trying to find some literature, of course. I looked at some project. You know very well, as we are here, the project Eurocode that is very famous and that is a base for the European policy on Alzheimer disease. I also looked closely at the project of Eurofemcare, which is also an European project, and I participated. But still, despite all these comparisons, we have difficulties in comparisons between countries because there are different types of services, different systems, and we are lacking data when on and where we need them, especially on care. And I also based this presentation on discussions with my colleagues and also on the knowledge of the situation because I usually ask my colleagues when we meet, and we are not so many people meeting and different international congresses and meetings, what's new in your country, so it's also based on my knowledge. And of course, it is based especially on my experience from the Czech Republic, because I am from Prague, from the Czech Republic, and I would like to introduce Czech Republic as an example because I will be showing also some problems, and I would like to be politically correct and not to criticize situation in other countries, despite I feel that it is to a certain extent very similar to the situation in our country. So now we can see that the life span is prolonging and the population is aging. It is not necessary to show it here. There are differences between European countries. These differences are going to diminish, but the purpose of showing this slide is also to show you that Czech Republic is in life expectancy at birth women, somewhere between Estonia and Poland, Slovakia, Hungary, etc. Very similar is the situation with the life expectancy of at birth of men, where we can, it is shown there in the picture, Czech Republic is somewhere between Poland and Slovenia. And the projection of life expectancy at 65 in women shows that Czech Republic is somewhere under the EU 10 average, between Latvia, Hungary, Estonia. And very similar situation is in life expectancy at 65 in men. Where Czech Republic is a small bit better on. It is in a European average between Hungary and Poland. Very similar situation in our position between other countries is, for instance, and it is just for instance, in public expenditures on long-term care. Again, we are between Hungary and Latvia, and also in some indicators of diseases. This is just an example of diseases attributable, of burden and death and disease attributable to stroke in selected countries. And again, we are a very comparable group of countries. And I wanted just to show that the example of Czech Republic and its experiences might be representative example for this situation. How it was in these Central and Eastern European countries since 50 still until 80s of the 20th century. We were constructing socialistic system. After that, we found that we have not constructed anything. But in Czech Republic, the socialist period was from 1948 until 1989, until the Velvet Revolution, as we call it. In the care, it was important that the state was the major and unique health and social care provider, because the state knew best what people needed. So all health and social care was coordinated by the state. Older people were sometimes called as overaged, and disabled people were sometimes called as invalid. And they were very often hidden in huge and sometimes very remote institutes, also in castles somewhere few kilometers from towns and villages and cities. And there are some bad examples, of course, but of course there are some good features of the system that should not be hidden. For instance, we had a pretty nice system of primary health care that was working. It was district health care. And since 1983, as an example of the Czech Republic, which I know, of course, the best, we had geriatric nurses that were very helpful to old patients. So I think not everything was bad, but still we were very happy that the Velvet Revolution came and that the political situation changed so rapidly and substantially. And now we had already 2 decades of changes of the society and its culture, changes of economical situation, first of all seen by many people, but not all, fortunately, changes of policies and also of healthcare and of social care. The situation before these political changes was very, very similar in these countries of the Central and Eastern European bloc, and because it was very centrally organized by the Soviet Union and Soviet politicians and experts and so on. And after these political changes, the situation started to develop differently in the different countries, but still there are many similarities. So I would like to show you both, but very briefly, and I said I am not able to bring all data on all aspects of care. For instance, in Hungary, they had very early the Act on Social Welfare. It was already in 1993. It stipulates that there are mandatory services in the community. They are provided by communities, including home care and rehabilitation that are funded by health insurance, but the community has the responsibility for support of care in families, home help, daycare, respite, and residential care. There is also nursing fee or care allowance, how we call it. In Hungary, they have the Council on the Affairs for Elders, and they stress in many materials still and everywhere, as we all in our countries do, the importance of role on families and also of neighborhoods. In their good practices, and it is derived from the Eurofem Care project, because I think you are much more aware with the Eurocode, they speak about health and social care integration in some major NGOs, not generally, but in some NGOs. They have some geriatric care models. They developed a geriatric methodological model, including education of professionals and so. And I liked that they have Ministry of Health, Social and Family Affairs. And despite this mentioning this interface of health and social care, I found in this report on Eurofem Care project written that the regulations strictly separate health and social care in the state sector, even though the state of older persons often calls for complex care. I think it is a very common situation as in many other countries. Further example is Bulgaria, one of the newest members of the European Union. They have also Social Assistance Act that came later than that in Hungary. It stipulates family care services, offices for family care, different other social services and allowance, and also municipal social assistance service, and with focus on family care, and other services are also stipulated by the Public Health Act. In Poland, they have also law on social care from 1998. Social care there is the responsibility, especially of local authorities. NGOs also play a very important role, and benefits are based on disability. They have also, as we all do, nursing homes and social care homes. Piotr Blindowski in 2005 wrote that differences in regional social policies for care depend not only on financial possibilities, but first of all on the awareness of citizens, activity of local authorities, and efficiency of the non-governmental organization. I think it is a very important illustrative remark. Very similar situation, a bit different but similar situation, is also in Slovenia, that has since 1997 national guidelines on care for older people. They also stress the role of NGOs, family care. In the Act amending Social Security, they stipulated care benefit for family assistance, and they run also different types of services, especially residential services and home services as well, but recently there is much concern about the quality of care in a care home. In our country, we have a new legislation in healthcare, and very rapidly we had a privatization of healthcare system. And since only 2006, we have new social care legislation. And recently we have discussion on long-term care that has started, and now we are preparing Plan Alzheimer. At least our government said that it would be prepared. But in our country, to be a bit critical, it looks like we have no problems. The care allowance is not based on adequate assessment. It is based only on the assessment of social worker. We have not defined role of municipalities in social care provision, and standard of social care and education very focus only on formal aspects. I am even speaking about this shaking of these all regulations, because we look at formal side of saying and not on the content. I think that quality of institutional care as topic is also a very important issue for public discussion. In Czech Republic, we have very high quality acute care. And for instance, our cardiological care is on very top among other countries. But we have very substantial problems with post-acute and chronic care and in long-term care. And there is a gap between the health and social care. And I can explain it, for instance, on the case of persons with dementia, because persons with dementia are too sick for social services and too chronic and long-term for healthcare services. In our Center of Gerontology, that I do not want to talk about because it is not the topic of my lecture, we provide different type of services. But it is not an example of the whole country, despite we talk sometimes about it. But it is not the situation in all country. And Czech Alzheimer Association tries also to give some recommendation, make pilot projects, but still it is not the situation in the Czech Republic. When we were sent, and it is a good example from the Belgian presidency, the questionnaire concerning different services, so we answered, befriending, yes, we have it. Daycare, yes, we have it. Home care, yes. Residential, yes. Night sitting, I'm not aware of. Support groups, yes. But unfortunately, this overview, which is important, does not provide information on the country as a whole, because to the question on quality, I had to answer, yes, it is mostly good when it is provided. And when you look at the set of answers, so you see that befriending is very rare, daycare is very rare, night sitting is extremely rare, if not existing, etc., and support groups also rare. So I think that surveys are important for basic orientation, but sometimes they can very bias the situation. And as I said, we have also differences in basic terminology. So it is very difficult to compare countries between themselves. And I think that good data, both quantitative for comparisons and qualitative for better insight into the situation, are very, very needed, especially in these countries. What has changed in our countries after 1999? The importance of role of families has changed, but it is still important in past, present, and future. The role of civil society is increasing. The development of acute health services, yes, I spoke about it. We have nice acute services. And we have decentralized both health and social services. We have also new types of services also in the social care. And now we discuss and try to develop also long-term care services. But these developments have also some buts, or many buts, because there is still remaining gap between health and social care. There is underfunding of care, insufficient support of family care, insufficient spectrum of services and their coverage, and also quality of services. I would like to stress low interest of politicians, both on the central and local level. I think colleagues from other countries would agree with me, and the need to integrate care at the patient's level. Dementia is a specific problem that needs better understanding and better solutions. And I would like to conclude with this, that problems, when we look at them, might seem very similar in all EU countries, but they are on a very, very different level sometimes. And now what to do? This is the last but one slide. We need to proceed in Alzheimer Europe efforts on the European level and in our efforts on national and local levels, and to be better listened to. And somebody in the morning, very morning, spoke about the revolution, maybe, to change the culture and values. And as we yesterday agreed and in the board, to foster research in health economics, social sciences and humanities, not only medicine and biomedicine, to better understand all aspects of dementia. Thank you for your attention.